Welcome back to the Deep Dive. Today we are taking a scalpel to one of the most high-priority, high-frequency topics out there, especially if you're preparing for any kind of high-stakes clinical decision-making. We're focusing entirely on medical situational awareness, specifically recognizing your own limitations and, crucially, how to escalate safely.
This is absolutely foundational. It's a must-know area, and it consistently scores in that moderate to hard range in situational judgment tests.
Why is that?
Because it forces you, the listener, to confront the hardest things, really. Ego, speed, and safety. Get this right, and you demonstrate real professional maturity.
Okay, let's unpack this then. We've been diving into a comprehensive stack of study notes designed for UK medical educators, and our mission today is to give you a shortcut to understanding the precise professional decisions needed when you hit a wall. And for those newer to the system, when we talk about GMC compliance, we mean the General Medical Council. They're the body that sets the ethical standard every UK doctor has to live by. This deep dive is where those standards meet the reality of the hospital floor.
And that is exactly where your professional integrity gets tested. Because the consequences of getting this wrong, well, they aren't just a low score. They involve potential patient harm and, even professional misconduct.
Let's start with a scenario then, one that really illustrates that conflict perfectly.
Okay.
Imagine this. You're the only doctor available on a night duty. A septic patient in resus is deteriorating rapidly.
Pressure's on.
The critical care team asks you, the junior doctor, to insert a central line immediately. They needed to manage overwhelming fluid requirements and get access. But you've only ever assisted with this procedure before. You've never performed one alone.
You can feel that pulse racing, can't you?
Absolutely.
The patient is crashing, the clock is ticking, and the expectation is on you to act. Now, so what do you do first? Do you attempt it because speed seems essential? Or do you pause, call for help, and potentially delay what feels like a critical intervention?
That tension, that pull between urgency and your actual competence, that's the key insight here, isn't it?
It's everything.
Okay, so if you had to boil all of this down to just one single sentence takeaway, the first thing that should flash through your mind, what would it be?
It has to be this. Pause when you are beyond your competence. Seek supervision immediately. Stabilize the patient with whatever interim measures you can, and transparently document your escalation plan.
So why does the exam mindset punish attempting something risky, even if you think you might succeed? The materials we've reviewed, they all emphasize that your core directive is to work strictly within your competence, seek help early, and make a safe interim plan. We're told over and over that safety beats pride every single time. But let's be real. Why is that cultural pressure to not call your senior so strong?
Well, that's where it gets really interesting, because it's not just a cognitive failure, it's a cultural one. Adverse event analyses, the research into why things go wrong, they often show the root cause isn't initial incompetence, it's delayed escalation.
Delayed escalation.
Yes, fueled by a fear of appearing weak or simply not wanting to, quote, bother a busy senior. The SJT tests if you have the maturity to overcome that exact cultural pressure.
So it's testing your ability to withstand that psychological discomfort.
Precisely. If a task is high risk or it's completely unfamiliar, the highest scoring action is always to stop, assess, and immediately get senior help. Your job is to show that you prioritize getting the right level of skill to the bedside.
Even if that means admitting your own limitation.
Especially then. The exam scoring logic, it heavily rewards early appropriate escalation. It rewards stabilizing the patient with safe interim measures. And it rewards clear, honest records.
So let's anchor this to the foundation then. This isn't just optional advice, it's actual professional guidance. The core principle seems straightforward. Recognizing your limitations means matching tasks to your current training, your skills, and crucially, your capacity. And then escalating before harm can occur.
And we can anchor this directly to the Good Medical Practice or GMP 2024 guidance. The GMC explicitly requires you to recognize your limits, to only practice with suitable supervision and support.
So that's a non-negotiable mandate.
Absolutely. If you're asked to do something you are not competent to do, your duty is to the patient first. And that means securing adequate supervision or finding a competent colleague. Raising and acting on concerns promptly is fundamental.
So in essence, you're obligated to seek help. Not seeking help is actually a breach of conduct.
That's right. So how do we put that ethical guidance into practice when, The phone is ringing off the hook and the patient is unstable.
Okay.
The sources provide a really clear high-yield framework that moves you safely from that initial recognition to the resolution.
Right. Let's walk through those 5 key actions in order, the sort of first, next, last framework.
Let's do.
Okay, number 1, scan risk and stop immediately. If the task is unfamiliar, high risk, or just exceeds your training.
The pause, the most important step.
Number 2, seek supervision immediately. Call your senior, call the crash team, consult local safety guidelines. Get help.
Yep.
Number 3, stabilize the patient and allocate safely. This means safe interim management while that help is on its way. This might mean allocating the task to a competent colleague if it's urgent, but usually it means doing the immediate safe things yourself. Number 4, be honest with the patient about what the plan is. Tell them who is coming and when the senior clinician will review them.
So important.
And number 5, document your decisions and the escalation. Note the time, the person you spoke to, and the exact plan you agreed upon.
Can I just dwell on that third point for a second?
Oh, yeah.
Stabilize the patient. It's where a lot of candidates falter. Stabilizing isn't just ordering tests. It's hands-on. It's basic life support.
A, B, C, D, E.
Exactly. Position the patient correctly, apply high-flow oxygen, check their vital signs, secure IV access if you can do it safely, and start initiating safe interim orders like basic monitoring or fluids. While you wait for the senior, you are holding the line until the cavalry arrives.
To make this stick under pressure, memory aids are essential. We've got 2 great ones from the material. First up, ASK.
Simple and effective.
A is for assess risk, S is for seek supervision, and K is for keep notes and keep the patient safe.
And the second one, which is more for the sequence after you've stopped, is STOP. Stop the action, talk to a senior, review the options, and implement the plan. You kind of need both. Use ASK for that immediate self-check, and then STOP for the management strategy that follows.
That makes a lot of sense.
Let's analyze the 2 scenario patterns where these principles get tested most often in the SJT.
Let's do it.
So pattern 1, high-risk procedure or consent. This is when you're asked to do something or consent for something that requires experience you just don't have.
Like the central line.
Exactly. The test here is understanding the difference between continued care versus safe practice. The best action is to explain your limitation to the nurse or colleague. Call an experienced clinician for direct supervision.
So not just on the phone.
No, direct in-person supervision. Then start the safety measures, like a timeout or appropriate prep. Offer to assist the supervisor so you can learn and document everything.
And what tempts people into the wrong options here?
Well, attempting it alone is obviously unsafe. That's a clear fail. But, and this is the subtle trap, simply refusing the procedure and walking away without making a plan for who will take over, that's abandonment of care.
I see.
That also scores very poorly. You have to secure appropriate care for the patient before you can step back.
And the second major pattern, the one that's often really time critical.
Pattern 2, the deteriorating patient, our sepsis example. The patient's decline is happening faster than your immediate skill set can manage. Here, that tension between immediate action and escalation is just paramount. The best action is always to initiate the ABCDE assessment to stabilize them yourself, while simultaneously calling the senior or the rapid response team. Now,
So you're doing both at once.
concurrently, yes, initiate the safe basic interim measures, oxygen, monitoring, fluids, and then document the plan, the timings, and who you called immediately. Escalation and stabilization have to happen in parallel.
Okay, now for my favorite part, the decoy detectors. The options that look reasonable but will consistently tank your score because they go against good medical practice.
Yes.
This is where we confront that cultural friction we talked about.
Right.
Trap 1. I'll just have a go to avoid bothering the senior. This must be the most tempting choice in a busy hierarchical hospital. Why is it absolutely unacceptable?
Because it's fundamentally unsafe. It breaches your GMP limits to work only within your competence. The GMC's view is completely uncompromising on this.
Yeah.
Seeking help doesn't look weak. It looks professional and safe.
And if the senior is hostile?
You document the hostility, and you proceed with patient safety as your priority. You might even have to escalate past that individual if necessary.
Okay. Trap 2. Walk away without a clear handover or plan.
That's the abandonment of care we just mentioned. You've recognized your limit, which is good, but you failed to secure the patient's next steps. You have to maintain ownership until a competent clinician has explicitly agreed to take over responsibility.
Okay. Trap 3. Ask a non-clinical colleague, like a healthcare assistant, to perform a clinical task you can't.
I mean, that's just incompetent delegation. If you're not competent, you certainly can't delegate it to someone who's even less qualified. It's completely unsafe.
And finally, trap 4. Write vague or incomplete notes after the fact, or pretend you did the task perfectly.
This fails the test of transparency. It's a probity issue.
Probity, meaning being honest and trustworthy.
Exactly. Clear, honest records are essential for continuity of care. You need to document who you spoke to, when, and what was agreed. It ensures transparency about the need for supervision. Our golden rule here is so important. Stop, seek, help stabilize, say the plan, sign the note.
Love that. Okay, let's hit the red flags. A quick fire round to show when intervention has to be immediate. These are the quick rules you can just internalize.
Okay, so if you encounter time-critical deterioration, your first 2 steps are immediate A, B, C, D, E, and calling the senior or rapid response team D and no W.
If the issue is consent or a procedure beyond your current competence.
The rule is simple. Do not proceed. You must escalate to someone who is suitably trained and can supervise you.
If you find yourself working alone without competent backup.
Immediately arrange supervision or, at the very least, a second checker to review the task before you proceed.
And if there is ambiguous ownership of a patient or a task.
Your immediate duty is to clarify. Find out who is responsible and when they will be reviewing the patient. Never, ever assume someone else has handled it.
A key question that comes up. What if the senior is off-site?
You still call them. You initiate the safe, interim, measures monitoring, basic treatment, the ABCDEs, and you escalate via the site manager or the critical care team if that patient needs immediate on-site senior input. And remember, just reading a guideline is almost never enough to proceed with a high-risk procedure alone. Supervision is mandatory.
Fantastic. So let's distill this. What are the 3 most critical points you absolutely must internalize from this deep dive?
Okay, 3 things. First, stop and escalate immediately when a task is beyond your current competence or your capacity.
Right.
Second, keep the patient safe. Use defined, supervised interim measures while you're waiting for help. And third, be transparent with patients and with colleagues. Be open about the need for supervision and what the plan is.
Perfect. Now, for the rapid recap, this is the ultimate sticky note summary of that we've just covered.
The highlights.
Stop if you're beyond your competence. Call a senior for supervision. That's your first step after assessing the risk.
Yeah.
Stabilize the patient. Provide that safe interim care.
Crucial.
Allocate safely or find competent supervision. Be honest about who will review the patient.
Yes.
And document the plan, who owns it, and the review time.
And finally,
remember, patient safety always, always outranks speed and professional ego.
If you remember nothing else, remember that.
Okay, could you give us that really short, concise summary paragraph, the kind of thing you'd see on Spotify?
Of course. This deep dive explored the high-yield SJT topic of recognizing your clinical limitations. We define the GMC expectation to always work strictly within your competence and establish the critical framework. Assess risk, seek immediate supervision, execute safe interim management, and ensure transparent documentation. Mastering this framework ensures patient safety, helps you navigate cultural pressures effectively, and achieves the highest marks in situational judgment assessments.
Great. And just to be crystal clear, let's quickly define a few of those key terms.
Good idea. So, competence. That just means matching tasks to your training, your skills, and your current capacity. It can change day to day. Escalation is seeking appropriate senior help or supervision before harm occurs. It's proactive.
Right.
Probity means being honest and trustworthy. That's particularly relevant to your documentation and record keeping. And finally, interim management. Those are the safe, temporary measures, like monitoring or starting basic fluids that you initiate while you're waiting for senior input.
This has been an incredibly high-yield session. We've dug into both the rules and the reality of it all.
Yeah.
The materials confirm that seeking help doesn't make you look weak. It makes you look professional and responsible. Recognizing your limits. It isn't just about protecting yourself, is it? It's primarily about protecting the patient.
Always.
We strongly encourage you to review your resources and check out PathMSRA.com for more study on this high-yield topic. And here's where it gets really interesting. A final thought. How often do you think delayed escalation rather than initial incompetence is the true root cause of serious clinical harm? It's often that delay, not the lack of skill, that really hurts the patient. Mull that over.
And remember to apply that ASK or SJT framework in your practice and in your study.
That's it for this focused deep dive. I'll catch you next time.